Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very useful tips which may prove very handy in your line of duty. So I welcome you all to part 108 of our pharmacotherapy MCQ series, Measuring in Infectious Diseases. Welcome. Our first question reads, Master KLN, a 5-year-old boy, presents to your pediatric clinic with a chief complaint of 2 weeks of purulent nasal discharge, facial pain, and the pain worsens when he's lying flat. He is allergic to penicillin, and the last time he took a penicillin, he developed a rash and itching. And the parent vows not to give KLN any penicillin products. So my question to you is, which of the treatment options listed below would be the most appropriate for KLN? Would you opt to treat him with clindamycin, levofloxacin, azithromycin, or cefixime? I'll give you 10 seconds to choose the correct answer. Levofloxacin would be the best choice here because the IDSA acute bacterial sinusitis guidelines state that respiratory fluoroquinolones should be used for children who are allergic to penicillins. I would like to remind you that third-generation cephalosporins such as cefixime should be avoided due to variable rates of Streptococcus pneumoniae resistance to them, and they are only recommended for children with penicillin allergy in combination with clindamycin, not as monotherapy. Now, macrolides should be avoided due to high rates or incidences of Streptococcus pneumo resistance, which is around 30% if I remember well. Then I would like to just remind you that gemifloxacin, levofloxacin, and moxifloxacin are the only fluoroquinolones that are FDA approved and commercially available that are considered respiratory fluoroquinolones, just for your information. Let's move to the next question, please. And it reads, what percentage of patients allergic to penicillins are likely to be concurrently allergic to cephalosporins? Is it 20 to 30%? Is it 1 to 3%? Is it 12 to 15%? Or is it 5 to 10%? I'll give you 10 seconds to choose the correct answer. One to 3% it is. I would like to start by saying that a type 1 hypersensitivity reaction is IgE mediated and often causes urticaria, angioedema, bronchospasm, pruritus, or anaphylaxis within minutes of administration of the medication. And the similarity in structure of the R1 side chains in cephalosporins and penicillins determine the likelihood of cross-sensitivity between the two classes. It's not the presence of the beta-lactam ring that determines it, but I'll repeat, the R1 side chain. Pay close attention to that. I'd like to remind you that the newer generation cephalosporins have different R1 side chains, and that makes cross-sensitivity low and the likelihood of allergic reactions even lower compared to some of the first generation agents and cephalosporins. And according to the current report, the risks for cross reactions to cephalosporins in patients with reported allergies to penicillins without skin testing is approximately 1%, but up to 3%, contrary to the traditional historic teaching, where most people approximated it at 5 to 10%, which was merely based on older literature. Now, current evidence suggests that cross-reactivity is much lower, but the exact incidence isn't truly known in the entire population. Now, if the sensitivity reaction was not type 1 or severe types 2, 3, or 4, cephalosporins could be used after careful evaluation of the timing of the reaction, severity of the reaction or the symptoms, and a structural comparison of the penicillin that resulted in that allergy and the cephalosporin that you are considering for use. Remember that. Let's move to the next question, please. And it reads, Mr. BBI, a 27-year-old male heroin addict, presents to your clinic. He has an MSSA in his bloodstream. He is diagnosed with tricuspid valve endocarditis. He has a past medical history of schizophrenia, for which he takes risperidone. And he's allergic to morphine. He tells you the last time it was administered, he had some itching. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Mr. BBI's management of this infection, this endocarditis? Do you choose to treat it with vancomycin, linezolid, nafcillin, or deptomycin? I'll give you 10 seconds to choose the correct answer. I would comfortably treat him with nafcillin. Remember, all of the other drugs could be used, but nafcillin is the drug of choice for MSSA endocarditis. I would like to remind you that vancomycin has been shown to be inferior to antistaphylococcal penicillins in the treatment of MSSA infections. And then data regarding linezolid and endocarditis is limited to case reports, and it should just be used as a last resort. Remember, the treatment is long-term, and if you use the linezolid beyond 2 weeks, then thrombocytopenia and other complications ensue because of the way it hammers the bone marrow. Let's move to the next question, please. And the next question reads, Mr. AHJ, a 71-year-old male patient, was admitted to your medical ICU due to severe influenza with respiratory failure. He needed ventilator support, and on day 3 of admission, Mr. AHJ isn't oxygenating well. His chest X-ray shows a new bilateral infiltrates. His sputum is purulent, and he has a past medical history of hypertension. He takes 75 milligrams of oseltamivir orally twice daily, and he receives 40 milligrams of pantoprazole infused over half an hour. He also takes 10 milligrams of amlodipine once daily, and he receives 40 milligrams of enoxaparin subcutaneously once a day prophylactically. Some of his pertinent labs include sodium levels of 138, potassium of 3.7, chloride of 98, bicarb of 20, a BUN of 18, and his serum creatinine is 0.8. He has a WBC of 18.9. Some of his vitals include a blood pressure of 154 systolic, 99 diastolic, a heart rate of 98. His body temperature is 102.5 degrees Fahrenheit. According to your medical ICU antibiogram, the Staph aureus isolates are MRSA approximately 20% of the time. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Mr. AHJ's case? Would you choose to treat him with Tobramycin plus Linezolid via IV route, or would you settle for Ceftazidime avibactam plus Ciprofloxacin IV, or would you settle for cefepime plus Vancomycin IV, or would you settle for Linezolid plus piperacillin tazobactam plus levofloxacin IV? I'll give you 10 seconds to choose the correct answer. I would settle for cefepime plus vancomycin, and I'll tell you why. Mr. AHJ's new onset infiltrates on the chest x-ray, his fever, the leukocytosis, and even the worsening respiratory status, while on a ventilator for over 48 hours, all meet criteria for diagnosing VAP. The most appropriate antibiotic regimen should consist of an anti-MRSA agent based on the ICU having resistant rates that are above the 10 to 20% mark. And it also needs one anti-pseudomonas agent for such a patient. Now the patient has no known risk factor for Pseudomonas aeruginosa that would require the use of 2 anti-Pseudomonas agents. So I would like to comment that answer B doesn't include an anti-MRSA coverage. And only one anti-Pseudomonas agent would be required, not 2. Both of them are anti-Pseudomonas, so that makes it wrong. Then answer A includes one anti-Pseudomonas agent and an anti-MRSA agent. However, the use of an aminoglycoside as the only anti-Pseudomonas agent isn't recommended in guidelines. Remember, aminoglycosides poorly penetrate the lungs and they have a higher risk of adverse effects, and studies have shown inferior clinical responses when they are compared to alternative therapy. So that would make that answer wrong. Then I would like to remind you that according to the IDSA, VAP, and HAP guidelines, patients with suspected VAP should receive empiric therapy that includes the coverage of Staph aureus, Pseudomonas aeruginosa, and other gram-negative bacilli. And the decision to include MRSA and dual coverage for Pseudomonas aeruginosa is based on assessment of the patient's risk. Now, the guidelines recommend coverage of MRSA if the patient has a risk factor for antimicrobial resistance, or if the prevalence of MRSA in such an ICU is either unknown or is known to be greater than 10 to 20%. Now, dual anti-Pseudomonas coverage is recommended in patients with risk factors for antimicrobial resistance, or if the susceptibility to anti-Pseudomonas antimicrobials is either unknown, or if the agent being considered for monotherapy has an resistant rate above the 10% mark. Now the guidelines name septic shock at the time of the VAP diagnosis and ARDS prior to VAP, or 5 or more days of hospitalization prior to the VAP, and even acute renal replacement therapy prior to VAP, and prior IV antibiotic therapy within the past 90 days as risk factors for VAP caused by multi-drug resistant microorganisms. Now, the prior use of IV antibiotics within the prior 90 days is considered the most predictive risk factor for VAP caused by MRSA and even Pseudomonas aeruginosa. Such patients with structural lung diseases should, in my opinion, be initiated with 2 anti-pseudomonal agents. Remember, the most recent H.P.B and VAP guidelines, if you refer to them on the internet, recommend antibiotics to be continued for only 7 days, regardless of the pathogen. So don't use those 2-week, 3-week therapies. Then I would like to mention that prior recommendations for longer days of treatment than, say, 12 days, for example, for pathogens such as Pseudomonas were based on single-centered trials suggesting increased relapse in those patients with the non-fermenting gram-negative pathogens such as Pseudomonas aeruginosa. So it was not based on hard facts. So you can comfortably stop treatment after day 7. Let's move to the next question, please. And it reads, Mr. FKO, a 46-year-old male patient, is admitted to your general medical ward with mitral valve endocarditis caused by MRSA. The infectious diseases team initially initiates Mr. FKO on vancomycin, and there is an increase in his serum creatinine from 0.5 at baseline on day 1 to 1 on day 3, and then to 1.2 on day 4 after initiation of the vancomycin therapy. The ID team decides to discontinue vancomycin. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Mr. FKO now? Would you choose to treat him with tigecycline? Or would you settle for quinaprisin, dalfoprisin? Or would you settle for deptomycin? Or do you think Linezolid would be the best choice? I'll give you 10 seconds to choose the correct answer. Deptomycin would be the correct answer here. Now remember, quinaprisin, dalfoprisin marketed as Sinacid, and even tigecycline marketed as Tigesil don't have data to support their use in patients with endocarditis and therefore are not appropriate options for this patient. Now, experience with Linezolid in endocarditis is limited to case reports, so I would not settle for it either. And I would just like to emphasize that evidence supporting deptomycin, marketed as Cubicin, includes a phase 3 randomized trial which led to the FDA approving it for this indication. So just like to remind you that it is FDA approved for this particular indication. Let's move to the next question, please. And it reads, which of the antimicrobials listed below is recommended as monotherapy for empiric treatment of febrile neutropenia? Is it ampicillin, sulbactam, unacin? Is it gentamicin? Is it piperacillin, tazobactam? Or is it levofloxacin? I'll give you 10 seconds to choose the correct answer. So piperacillin tazobactam would be the best choice. Now patients should be initiated on monotherapy with an anti-pseudomonas beta-lactam agent such as cefepime or a carbapenem such as imipenem, cilastatin or meropenem, or another option would be piperacillin tazobactam according to guidelines. Now all of the above mentioned agents are bactericidal in the absence of white blood cells with minimal toxicity. I'd like to add that levofloxacin has been evaluated in this setting, but there isn't enough data to recommend its use as monotherapy. It can be added to the initial antibiotic regimen of the management of complications, for example, hypotension and pneumonia, or in case of suspected antimicrobial resistance, not as monotherapy. I would like to add that aminoglycoside monotherapy shouldn't be used as empiric antibiotic therapy during neutropenia due to increased antimicrobial resistance. Remember, gentamicin has only gram-negative coverage, so it will not be very useful as monotherapy. Now, ampicillin sulbactam, on the other hand, lacks good Pseudomonas aeruginosa coverage, so it would not be a good choice either. Then I would like to add that ceftazidime is no longer considered first line for empiric monotherapy of neutropenic fever due to decreasing efficacy against the gram-negative microorganisms and its poor activity against gram-positive bacteria such as the streptococci. Now, while most patients with penicillin allergy can tolerate cephalosporins, those with hives and bronchospasms should be treated with ciprofloxacin plus clindamycin or aztreonam plus vancomycin in cases of such neutropenic fever. So just remember that. Let's move to the next question, please. And it reads, patient D.M.D is being treated with a vancomycin-containing regimen by your infectious diseases team. My question to you is, which of the monitoring parameters listed below would you pay close attention to in the course of treating Mr. D.M.D with such a regimen? Would it be bowel movements due to the risk of clostridioides difficile colitis, or would it be pulmonary function tests due to the risk of bronchoconstriction, or would it be renal function due to the risk of nephrotoxicity, or would it be liver enzymes due to the risk of hepatotoxicity? I'll give you 10 seconds to choose the correct answer. So renal function due to risk of nephrotoxicity it would be. Remember, the two classic and clinically relevant side effects of vancomycin are nephrotoxicity and ototoxicity, both of which are worsened when other nephrotoxic or ototoxic drugs are co-administered with vancomycin. Now, the main parameter used in clinical practice to monitor for nephrotoxicity are, for example, serum creatinine, the creatinine clearance, and even the trough vancomycin concentrations. Just remember those. Let's move to the next question, please. And it reads, which of the statements listed below corresponds to Isavuconazonium? Is it true that it binds to essential penicillin binding proteins? Or does it bind to dihydrofolate? Or is it true that it inhibits CYP450 dependent enzyme, which is lanosterol to be specific, lanosterol 14 alpha demethylase? Or is it true that it binds to the stem peptide of peptidoglycan precursors. I'll give you 10 seconds to choose the correct answer. C would be the correct answer. It inhibits CYP450 dependent enzyme lanosterol 14-alpha demethylase. Now, Isavuconazonium sulfate, which is marketed as Cresemba, is a prodrug of isavuconazole, which is an antifungal azole. It inhibits the synthesis of ergosterol, which is a key component of the fungal cell membrane, through the inhibition of cytochrome P450 dependent enzyme lanosterol 14-alpha demethylase. Now, this enzyme is responsible for the conversion of lanosterol to ergosterol, ergosterol. The accumulation of methylated sterol precursors and a depletion of ergosterol within the fungal cell membrane is what leads to weakening of the membrane structure and function. When that happens, the contents could leak. Let's move to the next question, please. And it reads, Miss TLP, a 6-year-old girl, is brought to your pediatric accident and emergency department by the mom, who informs you she attends daycare from 9 in the morning till 5:30 in the afternoon on all weekdays, Mondays to Fridays. The chief complaint today is purulent nasal discharge, facial pain, which has lasted 12 days. This young girl has a past medical history of transposition of the great vessels, and she is stable on presentation. So my question to you is, which of the amoxicillin doses listed below would be the most appropriate for Miss TLP's treatment using milligram per kilo per day? Would it be 60, 30, 90, or 15? I'll give you 10 seconds to choose the correct answer. C, it is 90, it would be. Now, the IDSA acute bacterial sinusitis guidelines state that high-dose amoxicillin regimens, which are 90 milligrams per kilo per day and up to a maximum of 2 grams orally, should be used in patients. It should be used for patients at risk of infection due to penicillin non-susceptible streptococcus pneumoniae isolates. So remember to dose it twice daily. Remember to divide the 90 milligrams per kilo per day in 2 divided doses. Now, patients at an increased risk of PNS isolates are those who attend daycare, those below the age of 2 or above the age of 65 years, those who are recently hospitalized, those who had an antibiotic within the past 30 days, those who are immunocompromised, for example, or those who have a severe infection, or those who live in an area where the incidence of resistance to PNS is equal to or above 10. So remember those small bits of information. Let's move to the next question, please. And it reads, your infectious diseases team is planning to discharge Mrs. D.M.D, a 77-year-old female patient whom they are treating for diabetic foot infection due to MRSA. Currently, she is receiving vancomycin infusions. They plan to do an IV to oral switch and currently she takes ferrous sulfate at a dose of 325 milligrams orally thrice daily, carvedilol 25 milligrams orally twice a day, 5 milligrams of warfarin once a day, 20 milligrams of fluoxetine in the morning after breakfast, and she has a past medical history of iron deficiency anemia, atrial fibrillation, and depression. So my question to you is, which of the medications listed below would be the most appropriate choice for this therapeutic switch? Would it be cotrimoxazole at a dose of 1 DS tablet taken orally twice a day? Or would you settle for 600 milligrams of Linezolid taken orally twice a day? Or would you settle for 300 milligrams of clindamycin capsules taken thrice daily with a glass full of water? Or would you settle for doxycycline at a dose of 100 milligrams twice daily orally? I'll give you 10 seconds to choose the correct answer. I would switch this patient to 300 milligrams of clindamycin capsules taken thrice daily orally with a glass full of water. Remember, clindamycin would be the most appropriate choice for Mr. D.M.D due to the drug-drug interactions with the other options. Remember, doxycycline is chelated by polyvalent cations. So their therapy using doxycycline would be challenging because he's already receiving TDS ferrous sulfate, and we know that it must be administered 2 hours before or 4 hours after ferrous sulfate dose for the doxycycline to absorb optimally. That would be a tall order. And then administering linezolid, which is marketed as Zyvox, which is a monoamine oxidase inhibitor, to a patient receiving fluoxetine would increase risks of developing serotonin syndrome. So I would not opt for linezolid either. Then administering cotrimoxazole to a patient receiving warfarin poses a significant bleeding risk, since cotrimoxazole increases serum warfarin concentrations, which results in an increased INR. So I would not opt for it. Let's move to the next question, please. And it reads, which of the following antibacterial agents is not FDA approved for the treatment of lower urinary tract infections? Is it Ciprofloxacin, marketed as Ciprofloxacin? Is it levofloxacin, marketed as Levaquin? Is it moxifloxacin, marketed as Avelox? Or is it ofloxacin, marketed as Tarivid? I'll give you 10 seconds to choose the correct answer. So moxifloxacin it is. Remember, the PK profile of moxifloxacin doesn't allow for adequate bladder concentrations. It isn't dependable for treating urinary tract infections such as cystitis because of that reason. I would like to repeat myself that moxifloxacin doesn't adequately get into the bladder due to its low glomerular filtration in the kidneys and even secretion into the renal tubule. Moxifloxacin doesn't require renal dose adjustment because of that reason, even in cases of renal impairment. Let's move to the next question, please. And the next question reads, Mr. H.P.B, a 55-year-old male patient, is admitted to your medical ICU with VAP. His sputum and blood cultures are positive for Acinetobacter baumannii, a terrible bug indeed. He is initiated on an antibiotic. He begins to develop an altered mental status. His serum creatinine rises from 0.9 on day 1 of therapy to 1.9 on day 3 of therapy. So my question to you is, which of the antibacterial agents listed below is most likely responsible for Mr. H.P.B's adverse events? That's the hit the kidneys are taking. Is it tigecycline? Is it ampicillin sulbactam? Is it polymyxin B? Or is it levofloxacin? I'll give you 10 seconds to choose the correct answer. Polymyxin B it is. Remember, polymyxins are known for their hallmark adverse events of neurotoxicity and nephrotoxicity. Remember, the kidneys are taking a hit and he has developed an altered mental status. Let's move to the next question, please. And it reads, a newly hired medical resident is on call and is managing a patient admitted to the general medical ward. Your microbiologist calls him with a critical value and informs him there is Pseudomonas aeruginosa that has grown in the culture of the blood specimen that was presented for culture and sensitivity. So the resident seeks your guidance as the clinical pharmacist, infectious diseases specialist attached to this ward on the best option from a list of Linezolid, ceftaroline, furosemide, cefepime, and ertapenem. So my question to you is, which of the 4 antibacterial agents would you advise this resident to initiate in this patient's therapy? Would you advise him to infuse ertapenem immediately? Or would you advise him to settle for Linezolid? Or would you advise him to infuse cefepime? Or would you advise him that ceftaroline, furosemide would be the best choice? I'll give you 10 seconds to choose the correct answer. I would advise him to treat this patient with cefepime. Now, the only listed agent with coverage against Pseudomonas aeruginosa in that list is cefepime, which happens to be a 4th generation cephalosporin. Remember, ertapenem is the only carbapenem that lacks activity against Pseudomonas aeruginosa. It also lacks activity against MRSA. I would like to remind you that ceftaroline, furosemide, and Linezolid both have coverage against MRSA, but absolutely no coverage against Pseudomonas aeruginosa. So all those many words qualify cefepime as the best therapeutic choice in this particular clinical scenario. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to remember to give it a thumbs up, to like it, and to share it widely with your peers. And if you haven't yet done so, I would like to humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come. And I thank you all very much for viewing this video, and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration. And I look forward to interacting with you in the next video. Thank you.